Hi, I'm Desmond Stutzman. I do hand and elbow surgery at OrthoNeuro here in Columbus, Ohio, and I'm talking about common hand injuries that happen in sporting activities, and I've chosen kind of a case presentation, individual cases that kind of bring into light things that could happen, and then not so much that we're going to concentrate on the specific injury, but what what other things you have to worry about, and when you really should seek the consult or the opinion of an expert. So the first presentation or the first case is a 16-year-old basketball player. It's probably happened to a lot of us, reaching in to try to steal a ball, jamming his ring finger. And the presentation's a simple one. It just basically some bruising into the finger, maybe some loss of motion, and depending on the severity of the injury, sometimes it could be very painful to the point where not so much pain at all. And so the first part of this talk in a simple finger sprain would be, is it broken? How do we tell? And really, for me, it's a no-brainer. X-rays are probably the most important thing when it comes to talking to an athlete after a bruising, loss of motion. It's just so hard for us to tell just with an examination. And there are several injuries that just seem to be a sprain. They linger, and then the patients come in to see me down the road, and it is in fact a complex fracture that requires operative intervention in order to prevent what these hands look like here. So finger sprains, back to finger sprains, just an injury to the collateral ligaments. Each joint in our fingers has a set of ligaments that brace the ligament or that brace the joint on either side. And these are the common injuries. A sprain, a simple sprain, swelling, bruising, as we talked. The more complex injuries are those that are on the volar plate. The volar plate is a ligament that actually prevents your finger from hyperextending. And these are difficult a lot of times in regards to the healing process because it can take up to 12 to 18 months for these to heal. Sometimes there's even a little avulsion fracture that's associated with these. And so, again, simple sprains, I always feel they deserve an X-ray just to make sure that you're not dealing with something that is very, very difficult in regards to a complex fracture. And so our evaluations, X-rays, a lot of times we'll do stressing of the joints because you can have a sprain that basically avulses an entire collateral ligament and create some instability. But again, for the most part, these are treated with very simple buddy taping. The return to activity is rather quick because we're going to obviously protect the fingers. In some of the higher contact sports, football, we'll place these patients into casts. And you know, the one thing that I think everybody needs to hear is that a simple sprain, even though we say simple, I mean, sometimes you get some change in the joint, meaning that the finger could be large for a couple of months, maybe up to 6 months. And pain for that 3 to 6 months isn't uncommon. And so they're a significant injury in some of these cases, but again, X-ray is needed. Our next injury is a football player that tried to make an attempted tackle, pain, swelling on more of the distal end of the finger. That's typically where this will occur at. The patient has some difficulty making a fist. And the surprising thing about this injury that we'll point out is that, again, a lot of times the severity of the injury is not really recognized. And so this is called a jersey finger. It's basically an avulsion of the flexor tendon that attaches to the very distal end of your finger. Patients reach out, they're grabbing to grab a jersey. The ball runner rips away, and the finger's then forcefully extended, and that force then pulls the tendon directly off the bone. Ring finger is the most common, and that's just has to do with anatomy. Sometimes you can pull off a bit of bone with this injury. the most important thing is that this one is one that sometimes looks like a sprain. And bruising on the end of the finger is very typical, but as you see, it is urgent for recognition of this injury because reattachment occurs, or you want to place the tendon back to the bone within about 10 to 14 days. If you think of our tendons as rubber bands, and when they're let go from one end, they'll retract, and that's exactly what happens with these types of injuries. The tendon can retract into the wrist or the palm, and if it's there for too long, then you can't bring that tendon back out to the distal insertion point, and then it becomes a very complex and catastrophic injury. Explaining this a little bit more, there's two tendons that flex your fingers, and so this is why the injury sometimes gets overlooked. The patients are coming off the field, will make a fist, and if you're not careful, you see in this picture here, the patient's making a pretty good fist, but the attachment to that very distal joint cannot be flexed anymore. And if you're not paying attention to this, it can be missed because obviously this patient can't curl that finger. Their flexor digitorum profundus has been torn off, and that obviously urgency to repair that in about 10 to 14 days. So here's just kind of the idea of the injury. The picture on the right really depicts how we repair this. It is nothing more than opening the finger up, grabbing the tendon with some suture, and then I basically place a button on the end of the finger to tie the tendon down. That's held there for about 8 weeks. The patient starts a rigorous range of motion therapy, and then we just basically clip the sutures and take that button off at about the 8-week mark. They can't return to sports until 3 months. Sometimes I'm a bit paranoid, and may even be a little bit longer than that if they're doing the contact sports that we worry about, such as football or wrestling. Next injury is a common one. Patient reaching out to dig a ball in a volleyball game, had some bruising on the wrist, didn't really think much of the injury itself, waited a couple of weeks to come in just because of the pain started to become a little bit more severe with activities. Initially, it was thought that it was just a simple sprain, so nothing was done. But then when the patient came in, we take these x-rays that you see on the right, and what we're seeing here is a crack right through the scaphoid, the bone in the wrist that is very common in fractures, and especially a fall on an outstretched hand. These occur in almost every walk of sports where there's a chance for a fall. And the injury itself is very significant only in the sense that, again, there's urgency with this one, as you'll see later, that finding these patients early really can dictate different types of treatment protocols. And so this bone has a very poor blood supply. When it is fractured, when it's broken, the area of the fracture as well as the timing becomes very important. And so these are commonly misdiagnosed x-rays initially. And the difficult part about this is that sometimes the x-rays initially don't show the fracture. It doesn't really show up sometimes until 2 or 3 weeks down the road, when this bone has started to go through healing, that we start to see the healing fracture line. And so again, that makes it very difficult. Patients with exams that really kind of exhibit this kind of worry, if we don't see any x-rays or any fracture lines by 2 weeks, they'll get an MRI or a CT exam. The slide really shows kind of the trouble with this bone. The blood supply enters distally in this bone. And so when you fracture out on the distal end, it's 100% of healing. But as you go more proximal in this bone, that's where it becomes very tenuous in regards to the blood supply. It gets disrupted. The fractures that are even operated on sometimes are very difficult to get to heal. And so when you look at the locations, the farther the fracture, the more distal the fracture, the more conservative we are in our treatments. Maybe casting, as the fracture becomes more proximal, the blood supply becomes more of a worry, and more of an aggressive treatment is indicated for those patients. And so the timing is very important, because a lot of times if these fractures aren't diagnosed a 2-week period, a non-union is higher, meaning that the bone just doesn't heal. Because again, this bone needs to be rigidly casted or fixed with surgery in order to maintain that blood supply so it doesn't get disrupted. And again, unfortunately, this bone is probably one of the more important bones in the wrist. Without treatment on this bone, you're going to develop arthritis and obviously later complications in life. Very quickly, skier's thumb is a fall on the slopes. This one's a common one. Patients with a fall onto an outstretched hand. You can see here the area of where the pressure comes on the end of the thumb. It can rupture a ligament. This ligament, called the ulnar collateral ligament, is very important even when you're grabbing a cup. This can create a great deal of instability. We want X-rays, a lot of times even MRIs, to look at this type of injury. You can see here we're doing a stress X-ray, which shows that the ligament here has been disrupted. And this one is a surgical indication only for the fact that if this joint becomes unstable and is left unstable, you're not able to even pick up a cup, or bigger problems down the road with instability and then eventually the development of arthritis. Again, if we can treat this non-operatively, if it's just a sprain, then we cast it for 4 to 6 weeks, sometimes can take 3 to 6 months. Surgery, if there is gross instability, which is easily diagnosed just with an examination. And I'm rushing through this last one so I don't get yelled at. That's my 10 minutes. I hope you enjoyed it. Let me hear your questions.